The other piece of it is that, from a perspective of these little small organizations, they are the economic powerhouse of these small communities.
So where do you see these PBMs can actually cut costs, especially when the incentives have aligned?
PBM is saying, of course, we took a look at our entire book of business, and because we put in these programs, which, healthcare is very hard to pinpoint to one particular program, is going to drive a variable, right, in driving costs down.
According to you, where do you see the incentive get misaligned, and how does that show up operationally to you? What should buyer understand about specialty drugs and pricing, dispensing incentives?
PBMs are going to be all transparent, and they're all going to be very clear with you, and that they're going to tell you exactly how they're going to get paid. That's not the truth, right?
Welcome to 340B Pulse, a Northart podcast powered by PureLogix. I'm Mohammad Atif, your host, CTO and founder at PureLogix and Northart. For nearly 2 decades, we have been building healthcare systems, data platforms, and compliance-heavy environments where percent really matters. Over time, that work pulled us deeper into real operational side of 340B, which consists of claim validation, reporting gaps, manufacturer requirements like ESP and Beacon, and ultimately program defensibility. And that's exactly why this pod exists. 340B Pulse is about operator-level conversations, no noise, no politics, but how this program actually functions day to day. I'm joined today by my co-host Hassaan, who leads program consultancy for digital transformation initiatives across 340B workflows.
Thank you so much, Atif. Excited to be here. Looking forward to really unpacking where actual friction shows up in 340B workflows, and especially at the operational layer.
Thank you, Hassaan. And today we are discussing a topic that continues to shape the ecosystem. PBMs, are these cost drivers or cost cutters? And from our work with small and mid-sized covered entities, we have seen how rebate structures, manufacturer data requests, and PBM alignment impact program risk and operational load.
And to help us explore this, we are joined by Jonathon Harrison, President and CEO of Wellyfe, a disruptive direct pharmacy care organization, redefining how employers, health systems, and communities access and pay for prescription medications. Jonathon is a pharmacist, entrepreneur, and nationally recognized voice in pharmacy benefit reform. He founded Wellyfe to challenge the traditional PBM model by eliminating spread pricing, increasing transparency, and realizing incentives so the employers save, health systems retain revenue, and patients pay less at the counter. Under his leadership, Wellyfe has pioneered a direct pharmacy care model that has been independently validated for measurable savings, proving that pharmacy can operate without opaque rebate structures or hidden margin layers. Jonathon is passionate about restoring local pharmacy sustainability, optimizing compliant 340B strategies, and building fiduciary aligned pharmacy benefits that put patients and communities first. Jonathon, a very warm welcome to 340B Pulse, and we're glad and very excited to have you here.
Thank you so much. I'm excited to be here as well.
Thank you, Jonathon. So before we dive into specific topics, so can you please share about your journey into the PBM space and what keep you focused in this space day to day?
Of course. So my background as a pharmacist is a little all over the place. So I've done a little bit of everything, right? So retail pharmacy, specialty infusion pharmacy, director of pharmacy for federally qualified health centers, where I became a 340B ACE. And then I kind of fell into the PBM space in terms of, pharmacy benefits consulting. And ever since, pharmacy school, I've always had this idea of why do healthcare organizations need a PBM, right? Healthcare organizations have almost every bit and piece of what a PBM does except an adjudication platform. And so it took me, 12 years of experience in those kind of different realms of pharmacy to put together what direct pharmacy care looks like and what Wellyfe looks like. So, for me to be kind of just anchored in the space of creating a healthier community health, anchored in the space of making sure that organizations can stay financially afoot, even with 340B under attack from manufacturers, et cetera, right? So that's really what grounds me, is making sure that individuals within communities have access to the care that they need.
Awesome. Yeah, I think that's really great, motive and the vision. that communities who deserve, they have access to the care. So, Dr. Jonathon, so when did you start at Wellyfe? Can you, like, how long you been?
Yeah. So Wellyfe's been around for about 4 years at this particular point. So a lot of it in the beginning was, of course, the grind of creating, systems, creating data platforms and things that we needed in terms of being able to really not only, kind of align the PBM space to 340B, but to really wrap around it and integrate it. So when you have the traditional PBM that tells you that they understand 340B and that they can do certain things with 340B, that's just a sales pitch, right? Yeah. Wellyfe truly has the expertise in integrating the 340B program and covered entity status into the claims adjudication process. It's more known or closely known as being a PBM, right?
Great. Yeah, that's great to know. So, at a high level, how do you define PBM's intended role in today's ecosystem?
Yeah, I mean, the intended role in today's time is to make shareholders money, right? PBMs are out there to create wealth versus what they were originally intended for, right? And that came about because of vertical integration. And so you have organizations that, because they own every aspect of the drug supply chain, whether that's, the insurance level, the PBM level, the specialty pharmacy, the pharmacy level, and now provider level, there's really only one thing that they're after at that, is to make sure that none of those dollars exits that vertical integration. So, what we do is we essentially use those same tactics. It's just we create it on a community level so that the community can keep that money and use that money to reinvest in its healthcare organization so that, again, our communities can take care of one another.
Yep. I think that should be the motive. So, what do you think about the rebate pilot conceptually? Like, what operational capability does it force teams to improve, even if timeline shift?
I think it's silly, right? To have a rebate model. We know that the rebate model doesn't work in pharmacy benefits. So why are we doing it within the 340B space? Right? I mean, if you take a look at PBMs, rebates are kind of a black box gray area. Yeah. We don't know how much is actually attributed to each drug. Who knows if there's any attempt from the PBM to keep some of those rebates, because again, their formulary is created based off of those rebates so that they can create additional revenue for themselves. So why are we doing this for 340B? We need to really take a look at 340B in general, right? There's a large spectrum of organizations in 340B. You have the covered entities that are federally qualified health centers, black lung clinics, STD clinics, tiny, don't have the operational bandwidth to take on more workload. And then you have large academic centers and large hospitals that, because they're a DISH status or because they've, are qualified one way or another for 340B, they have the money to essentially create operational pieces and parts for the rebate model or any other data extraction that the manufacturers are looking for. So what we're really doing is we're taking this, regulation, right? This rebate reform or model, and we're punishing the small guy, the FQHCs, while it doesn't really phase the hospital side of things. And so maybe they should have thought about doing the rebate model for hospitals and not touched
the small guys.
The FQHCs, because at the end of the day, most FQHCs are not profitable, right? They're they are truly nonprofits, and most of them are losing money. On a regular basis, right? They're operating in a deficit space. And so that was one of the reasons why we developed direct pharmacy care as another service line, another revenue generator for these organizations to stay afloat.
Got it. So when you say black box, like, do you have any recommendation, like how it can be like improved, or what minimum controls that you would want in place before any rebate style model becomes real?
Well, I think they have to figure out what this is operationally going to look like, right? I think the pause on the rebate model, if you can't fly a plane while you're building, it's a very great analogy, because that's essentially what they're trying to do. Yeah. Let's get this plane off the ground. Their screws are loose, and we have to just quickly try to patch the wings, patch a hole here. Let's get the rivet guns out. And it's only going to hurt the small organizations, the small communities, the ones that are in rural health, the FQHC that's the only place of care for 100 miles.
Yeah.
And who actually is getting hurt in that space? Well, the community, because there's no care. So now you have to drive to get to a regular, physician's appointment. Good luck doing that, especially as gas prices continue to increase, right? The other piece of it is that, from a perspective of these little small organizations, they are the economic powerhouse of these small communities. They're the major player within the employer space. You take away that, then all of these people are going to have to move. So you have this re-urbanization, right? We are going to see people in mass exodus leave rural areas to go back to being in urban areas, which isn't great because you can't farm in the city. Yeah. Right? You don't have hundreds of acres to have cows and grow produce like you do in the rural areas. So we're going to see a shift, and it's not going to be a good one.
Yeah, and Dr. Harrison, one of the very important things for these PBMs is cutting costs. So where do you see these PBMs can actually cut costs, especially when the incentives have aligned?
I've seen a lot of organizations claim that integration makes them cheaper, makes them more effective, makes them be able to close more care gaps. And that's, I think, further from the truth, right? I think the big piece of it is anytime you have a PBM that's going to ask you to put in clinical programs, $3 PMPM, PEPM, all of these different fees, they all kind of add up, right? And at the end of the day, your CFO is not really able to really get a picture of how much they're actually spending on the administration of their pharmacy benefit. It's still misaligned incentives, right? And from a cost-cutting perspective, the data really isn't there to show that clinical programs reduce, cost. And I think it kind of goes back to the bias of the research. Who's the one doing the data analysis on all the data that they're pulling in? Is it a third-party vendor? No, it's the PBM. The PBM is saying, of course, we took a look at our entire book of business, and because we put in these programs, which, healthcare is very hard to pinpoint to one particular program is going to drive a variable, right, and driving costs down. So when you have the fox that's guarding the hen house tell you everything's fine, we're reducing costs because, we've taken a look at our book of business and this is a great program, it's hard to believe.
Yeah. So it is a very complex structure, and you're saying that the innovation has its own challenges. But if you were to highlight 2 or 3 green flags in the entire PBM model, what would you say are the green flags in the PBM model today?
Well, I think the ones that are out there that are truly being upfront with organizations and clear with organizations, I kind of hate the word transparency at this point because it feels like a spectrum, right? Just because something is transparent doesn't mean that it's, overtly clear, right? You can still have, a transparent window, but if it's foggy on the other side, you're not really getting the full picture, right? So making sure that you have a benefits consultant or a pharmacy consultant that's able to read those contracts and find the terms and conditions that are kind of gotchas, or find a vendor that doesn't have any gotchas, right? You might be changing some wording in terms of red lines in their MSA or contract, but there's no overt red flags, right? And I think that's one of the biggest green flags is, when you have an organization that really truly wants to be a partner, not a vendor, share in that kind of model of growth, model of, well, when you do well, we do well, then you align those incentives, and it creates, kind of just creates this PBM model. It goes back to maybe what it was originally intended for, right? To actually reduce costs, to actually reduce the healthcare spend for employers on their employees, while also making sure it's not just saying it's an expensive drug, we're not going to fill it or cover it, right? We want to make sure that member still gets the opportunity to have the health outcome that they want without essentially just putting up red, barriers or red hoops to jump through for them to get a certain medication.
Yeah, so I think I totally agree that having a consultant or benefit consultant vendor who's really expert in the domain will really add the value. So Dr. Jonathan, according to you, like where do you see the incentive get misaligned and how does that show up operationally?
The incentive gets misaligned when you have 15 different ways a PBM makes money.
Mm-hmm.
So you've got a rebate formulary placement fee that they're getting. They're getting some sort of admin fee from the actual employer. They're receiving clinical fees, PMPM fees. You have other particular programs like they have copay maximizers or they have patient assistance programs that they're keeping a 25% of the savings when it's a form that, it should not be 25% of the savings, right? I think as you add all those things up and as you create more and more revenue streams, the more and more misaligned that PBM becomes, right? So finding organizations that have very minimal or 1 to 2 revenue streams makes sense, right? Because at that point, you don't have to kind of watch out for the other 13 or 14 ways that they're trying to make money. You're able to really focus on, okay, this is where you're making money. This is the actual benefit that you're bringing me. Is it worth it or is it proportionate to what the value is of what we're paying you, right?
Got it. So having less distraction, like as you keep adding more like revenue stream, it will just be more distractive and you will not have clear picture how to max out. So having defined 1 to 2 revenue stream, right?
100%. I mean, when a CFO has to chase 15 different things in a contract in terms of how much they're making, it's going to be very difficult. So for example, PA fees, so prior authorization fees, the PBM controls the formulary, which then controls the utilization management, which is the PA bucket. So they're going to charge you anywhere from $55 to sometimes $400, depending on if it's a first-time PA an appeal or if it's a peer-to-peer. There's no way to track. Well, there's no way to really figure out how many prior authorizations you're going to have next year. So it's kind of just a guess. So where a lot of organizations are making money are in this big clinical bucket that they say, okay, we're going to charge you PA fees. And well, that's just the name of the game. Well, they control the formulary. They control the PAs on that formulary. They're also kind of controlling their own revenue stream, right? The more PAs, the more money I make. Seems like a perverse incentive. Doesn't really drive clinical value to your client. It just drives dollars to your shareholders.
Got it. Right.
Mm-hmm.
And how do rebate structure and formulary placement sometimes distort behavior?
I mean, the entire formulary is created based off of rebate-driven tendencies. So the more money an organization, a manufacturer is willing to give me to put on a formulary, and if I'm a big PBM, then I'm going to put them as a preferred drug because you're going to pay me more than another. The other aspect of it is now you have organizations that have offshore group purchasing organizations. So what that means is that manufacturer sends over a formulary placement fee to these GPOs or to these other organizations. They keep a percentage. So let's say they keep 10%, which we know it's more than that. The other percentage is then relabeled a rebate and given back to, say, your large organization or your client, etc. Again, you're creating kind of just a ball in a cup situation. You're trying to find the money and where is it going? If the rebate model, again, kind of going back to that, rebate model in 340B, if it doesn't work for PBMs, why are we trying to put it into 340B, right? Drugs aren't a 4-pack of tires. When you go to the car shop and you buy a 4-pack of tires, there's a mail-in rebate that comes with it. You as the customer get that money, not the entity selling you the tires. So why is it so different for pharmacy benefits? Why is it going to be so different for, the 340B program? It really just doesn't make sense. It's baffling me that they're still thinking about putting this program into place.
Got it. Yeah, that totally makes sense. So according to you, what should buyer understand about specialty drugs and pricing, dispensing incentives?
Well, specialty pharmacy is 1 to 2% of your claims, and it drives between 40 and 60% of your spend in terms of your pharmacy benefit spend. That's a lot of money. the PBMs essentially get to create what their specialty drug list is. So we have a client in Idaho that they were purchasing drug, dimethyl fumarate, through their PBM, which I will not name, for $8,000, a little over $8,000, it was like $8,500. If they bought the drug through their wholesale catalog at their pharmacy, the drug costs $150. Now,
Wow.
that's not even the cheapest you can get that drug, because you can get it through, a Mark Cuban's Cost Plus drugs for about $35. So what makes this drug so special that the price can range from $35 to $8,500? And the answer is because someone decided to put it on a specialty list. That's
Wow.
it.
No, that is a very interesting take on specialty drugs. We've talked about the cost cutting. We've talked about the cost drivers right now. What are your thoughts on how the space is changing right now, especially with all the scrutiny, with the PBM scrutiny that is coming up? And another question along with that is, does it really matter to plan for sponsors?
I think organizations are starting to want something different, right? We're seeing more and more organizations move away from the traditional big PBMs to smaller PBMs that do things differently. They might pay more in an admin fee, or it might seem like they pay more in an admin fee, but in the actual end of the day, it's a clear payment versus, again, those 15 ways a PBM makes money.
Yeah.
You're able to just kind of get down to brass tacks of saying, yeah, if you're going to spend $150,000 on your admin of your plan, that's it. That's all it is. There's there's PA fees we have to take into consideration. And then there's, the percentage of savings on our patient assistance programs. And then there's X, Y, Z. At the end of the day, your CFO is having to run a bunch of different numbers to try to figure out what you're paying. And at that point, it's still wrong, right? You still get a check or a bill at the end of the quarter, and you're like, what happened here? What went wrong? Oh, you had additional PAs, and some of them were appeals, and some of them were this, and yada yada yada. It becomes an issue. So why is this important to plan sponsors? Well, it's time to wake up. Right? It's time to take a look at your pharmacy benefits and have a conversation with your benefits broker and realize how they're getting paid too. Because at the end of the day, benefits brokers can sometimes bake in fees into the PBM. So whether it's a per claim, whether it's a per member per month, benefits brokers are also sometimes making money where they shouldn't be, or offering services that clients really don't need.
Yeah. No, the CFOs already have a lot of challenges. Lack of planning is just adding to those challenges. So yeah, I agree with you 100%. In terms of the transparency expectations, they're also rising. So how should a hospital or a FQHC or an employer prepare for such an environment where the expectations keep rising with respect to transparency?
Well, I think a lot of that comes to the vendor relationship. And so, again, it's reading the contract in terms of what is their definition of transparency, right? Because, again, transparency can be that large spectrum. Just because a salesperson comes in front of you and says that we're transparent, if it's not backed up in the contract, it doesn't matter, right? As a pharmacist, I was always taught if it wasn't written down, it never happened, right? So that's essentially going back to charting, right? Having conversations with patients, making sure that you're charting everything. Because again, if you didn't write it down, if it's not documented, it never happened. Same thing happens with PBM contracts on a regular basis. Your salespeople, your marketing team touts transparency, and then you get to the contract and that word's not even in it, right? It's a 90-page document. You're like, where is that term? I don't see it. So making sure that you have performance guarantees, making sure that you have guarantees specific to around that transparency, making sure that you own your own data, that you can look at your own data, analyze your own data is incredibly important, because sometimes they'll write in there that it's proprietary and that they're not going to give it to you, or, you'll ask for data and it takes 6 months to get. If it's your data, you should be able to get it whenever you need it, not have to jump through hoops to receive it.
Absolutely. So the way to keep up with the transparency expectations is to make sure that transparency is mapped into the agreements, into the paperwork, and it's just not a sales gimmick. So that would be a way to keep up with the expectations. And today you've talked a lot about the CFO. So I've been wanting to ask this question. If you were advising a CFO what 5 questions should CFO ask their PBM on their next renewal, let's say?
That's a great question. I think number one is, what are all your revenue streams? Mm-hmm. I want to know exactly how you're making money from us. Number 2 is more of a question of, well, how much is my broker getting paid out of this too? The third piece is, have you been externally validated? So there's companies out there like the Validation Institute that will essentially take a look at financial models or look at PBM contracts and validate those contracts to essentially say, hey, listen, you went through a rigorous test. We took a look at what you've got, and what you say is what you do, right? It's always that trust but verify. So have you ever done any of those types of things? The other ask is references based off of whatever your company is in, right? So for example, if you're in tech, if you're a technology company, does that PBM service any other technology companies that are similar in size to you? And if so, can I get connected with that individual so I can have a conversation, right?
Yeah.
And I think, the last piece or the last one is really is asking the question, what does transparency mean to your organization? And maybe asking that question to a couple of different people, because if you have different answers across the board, there's where that spectrum comes in. And if you're asking a salesperson versus you're asking the CEO, or you're asking, the individual underwriting your deal, you get much variation out of those. That could be a problem.
Yeah. So transparency is very subjective, and it matters which person you're speaking with, and their understanding of it would be very different. But essentially what you've said is that the CFO should be keeping track of all of their revenue streams. They should know how their brokers are getting paid. When they're speaking with these organizations, they need to ensure there's external validation. And in case of working with a technology vendor, speak with other customers that they've worked with, ask for references. So that is a very good advice, I think. Staying on the topic of CFOs, another very important thing is, what metrics should a CFO be tracking? What are the important metrics for a CFO?
I think that's a difficult question, especially when it comes to pharmacy benefits, because those needs change over the course of year to year, right? So let's say I get sick and I have to be put on a specialty medication that is a very expensive drug. And it's not something I can do without. At the end of the day, I may not have needed that last year, but I need it this year. So really having a team of benefits brokers and having kind of your CFO really engaged with that group to talk through, what does quarterly business reviews look like? What does the benefits costs look like? And where are we at trend-wise? Are we above trend, below trend? Are there outliers? Really, are there individual claims that are kind of ballooning our spend that are out there, right? It's a one-time thing. So for example, sometimes NICU babies can come up on those types of claims. And so when you're taking a look at that, it's, well, hey, we don't expect to have a few more NICU babies next year. We had one this year. Yeah, it's a $250,000 claim. We hit our stop loss, et cetera. We need to move forward. It's really just making sure that you're following that trend and following up on things so that you don't get surprised. Hey, we've got a new member that came onto the plan that has, a specialty disease that needs a specialty drug that's very expensive. You need to be tracking that so that, hey, this person's going to be on it forever, or is this a 6 month to 8 month treatment? We really need to focus on the finances of, especially in the self-funded space, of where those claims are going to be in a year, 2 years, 5 years down the road.
Yeah. So looking at the trends, tracking the outliers, CFO grade reporting is obviously, like you said, is changing. The needs are changing, so things would change in it. So I understand that. And I think a lot of CFOs would relate to what you're saying, and they would really appreciate some of the answers that you've given. And in terms of the PBMs again, what is one myth that you would like to correct about PBMs? Do you have anything that comes to mind?
Yeah, one myth. I mean, I think at the end of the day, organizations forget that they're businesses too, and that there are ways that they're going to make money that as long as you're transparent about it, right? There's that word again. As long as you're clear about it and you tell them exactly how you're going to make money and why and how it's proportionate to the value that you're bringing to them, then it makes sense. But the myth of kind of that PBMs are going to be all transparent and they're all going to be very clear with you and that they're going to tell you exactly how they're going to get paid. That's not the truth, right? It's a big myth. They're just another vendor that you have to check the contract. You have to make sure that there's no gotchas. You have to make sure that they're really aligned with your values philosophically as a company, right? So as a benefits broker, just because a group can save you money doesn't mean that they fit your organization from a benefits perspective or from just a philosophical standpoint of what your company does, if that makes sense. So really making sure that the company aligns on multiple levels, not just the cheapest dollar. Because if they're throwing out the cheapest dollar, sometimes you get what you pay for, right?
Yes.
Yep.
Mm-hmm.
Yeah, so I think that makes sense. So you nearly tried that. It's not just about the PBMs. Whenever you're working with any vendor or any group, you need to go through the paperwork and everything in details and need to make sure that you are getting the value that you are paying for. So, Dr. Jonathon, we have talked about in this podcast, starting from what is a PBM role, then rebate pilot, and its efficacy. We have talked about minimal control set, cost cutting, and finally, what I have seen in this overall board that you've been focusing on transparency, reporting, and having the clear visibility. So tell us about like how do you take care of these challenges and operations? Are you using any kind of technology, any software, any AI to stay ahead of these challenges?
Of course. So, from a PBM perspective or direct pharmacy care perspective, because that's what we call it, we have a number of different technology platforms and, we've started to integrate AI. So certain things in terms of, creating, dashboards, data analysis, those types of things that, a CFO doesn't have time to go through and click. As cool as it would be to give them a huge dashboard that they could play with, we have that option, but they don't have the time for it. So they can, essentially type in, hey, I'm looking for a report to do X, Y, and Z. Can you run it for me? It pulls up the data specs. It does it. It gives them an opportunity to take a look at that data in real time and say, okay, we need to make decisions that are going to change or be actionable towards this trend or X, Y, and Z. So for us, it's all about staying ahead of the curve is really just being technologically advanced, right? And if you're not with the times, then you'll be behind the times. And that's really how we stay in front of, the vast majority of issues when it comes to, the operations perspective of the direct pharmacy care model, which is a little different than your traditional PBM model in general. But technology is the backbone of what PBMs do.
That sounds great. And it seems like you guys are using some really advanced AI and tech already where you can prompt and get a customized report. So that sounds great. So Dr. Jonathon, before we wrap, what advice would you give to the cover entities or employers trying to navigate PBM relationship and rebate structure today?
I think the biggest piece is to have those conversations as early as possible, right? There's lots of roadblocks that your medical TPA will put into place, that your existing PBM will put into place to try to slow roll you or stop you from making a change. Get involved with your benefits broker early, have them start an RFP process, have conversations. For us, we do our data analysis for free. I get organizations that reach out all the time and want to take a look at, the numbers that we're able to save. And 60% on average, it's a fair bit of money that these organizations can save that they can reinvest into their organization, whether it's through additional FTEs, service lines, additional charity care. And it happens to be that, the market is needing that right now with the 340B program potentially going into a rebate model with just inflation in general, the cost of drugs being more expensive, it's the perfect time to start taking a look at how do I save money, but also create new revenue all in the same vein.
Got it. Yeah. Thank you for that advice, Dr. Jonathon. And Dr. Jonathon, those who are listening and who may want to connect with you or learn more about Wellyfe, What is the best way to reach out to you?
Yeah, there's two ways, right? So there's through our website, which is www.wellyfe, WELLYFE-RX.com, or through our LinkedIn. So we are massively present on LinkedIn, both myself, Dr. Jonathon Harrison, or Wellyfe as well. We're posting on a regular cadence. We can definitely get contact requests and support through that as well. And honestly, it's just about having conversations, right? Even if we can't help you, which we've talked to a lot of covered entities and there hasn't been one that we haven't been able to help. We're just generally trying to change the model. We're trying to bring back that community healthcare feel like I had as a kid, right? With our pediatrician that was down the street, it was like 5 minutes away, locally owned organization, a locally owned independent pharmacy. You got seen, you got your prescription for amoxicillin, you walked over next door and you got your drug. They don't exist anymore. That building is torn down. It's sad. And so as a pharmacist, I want to get communities back to that, back to caring for one another, creating a sense of community again.
Sense of community. There you have it. Dr. Harrison, thank you so much for joining us. This was very thoughtful and grounded, exactly the type of conversation 340B Pulse is meant to bring forward. Thank you so much.
Thanks for having me.
This has been 340B Pulse, powered by North Arc. We shall see you next time. Thank you.